I'm talking about digestive pathology. And I am going to lecture fairly quickly. I'm recording this, so I'll be working off these two systems to record, and I'll try to make this as short and sweet as possible. Okay, so we'll start with a review of anatomy and physiology of the digestive system. I'm just going to be focusing on the digestive system, but a lot of it interconnects with other things, so we'll talk some about the hepatic system, but I'll save those things. So there'll be a few parts where I'll ask you to kind of bookmark something, and we'll come back to it. We're going to talk about the tubes and catheters that frequently we see in the digestive system. And then we're going to detail occurrence, signs, treatments. That's DX means diagnosis, TX means treatment of the following pathology, to include a big long list of things. And I'm not going to go into it right now, but there's a slide for each and every one of these, as well as x-rays for each and every one of these. And I focus primarily on just the x-ray, how the pathology presents on x-ray. And then we'll finally just talk about the subtractive radiographic techniques, because there's a really super common registry question that is probably the most important in terms of all the additive subtractive questions, relates to the digestive system. And it's so backwards that I want to make sure that we are really clear on that. So towards the end of the slideshow, I'll be talking quite a bit about that. All right. So for the quiz today, I think there's at least 2 questions on this, right? And on the exam, there will also be questions about this, because it is very important that we can orient ourselves in terms of these different planes of the body. So there's the RUQ, LUQ, LLQ, those ways of looking at things, right? And they're pretty straightforward. Like very often appendicitis manifests as RLQ pain, right? And we'll talk about how diverticulitis a lot of times is called left side appendicitis, right? Because it's the same pain, only it's on the left side, right? So being able to orient ourselves to these different planes is important, but then also being able to imagine what anatomy underlies those planes is helpful. So for example, the liver lies primarily in the right upper quadrant, or we can also say the right hypochondriac into the epigastric regions if we're looking at like the Addison planes, right? So make sure that you're familiar with those planes and you can identify what anatomy and what organs are in those general areas, okay? The other way of thinking about the abdomen anatomy is to consider the peritoneum, which is that serous membrane that I kind of think about as like a garbage bag that's inside of our bellies, right? And there's some things inside of the garbage bag and there's some things outside of the garbage bag. So it kind of folds down through the area of the abdomen and loosely holds things together. So the visceral peritoneum is the lining as it attaches to the organs, right? And so I don't know if it has it on this illustration here. The actual parietal peritoneum attaches to the abdominal wall itself. That's going to be important. That visceral peritoneum and parietal peritoneum will come back up when we talk about the liver, right? Because again, some of the organs that are there are attachment points there. There's also a mesentery, which is a double fold of parietal peritoneum from the abdominal wall to the lumbar region. It's a fairly large area, right? So it goes from the abdominal wall to the lumbar region. We call it the mesentery, right? And then the greater omentum is this double fold attached kind of inside that to the duodenum, stomach, and transverse colon, right? And then the lesser omentum attaches the liver to the lesser curvature of the stomach and the duodenum, okay? So what I'm mostly interested in is definitionally, can you tell me where these things are and what they are, right? So this slide is one of those that it's just going to be helpful to know what these things are. What is the parietal peritoneum? What is the visceral peritoneum? Those types of things. I don't think I ask any questions like where does, for example, what's inside of this or what's outside of that, unless it's very general stuff, right? So I'll be very specific about what you need to be able to identify as inside or outside, okay? So just know that this slide is for definitions. This slide here gives us more of what's inside and what's outside. So in terms of this, these are the things I wanted us to be able to say, okay, that's retroperitoneal or behind the peritoneum. Cecum, ascending colon, and descending colon. Now, Bookmark that, because there's one of the things that is retroperitoneal that's important, and that's the kidneys, right? The reason that that's important, that the kidneys are retroperitoneal, we'll get into when we get to the kidney things. But just know that organ-wise, kidneys are retroperitoneal. For the purposes solely of the digestive system, it's the cecum, ascending and descending colon, right? So most of the large bowel. Intraperitoneal, which means within the peritoneum, is the hepatic flexure, transverse colon, splenic flexure, and then the sigmoid colon, right? So all of that's tucked inside of the peritoneum. And then sometimes we talk about things being extraperitoneal. That's the rectum, right? So it is helpful to be able to identify these parts of the bowel as within these areas. And the reason why this is important is it's significant, and it's going to play a part in some of the pathology that we're looking at and some of the imaging procedures that we actually have to do. Okay, so this isn't just an academic discussion. This does play a part in the way that we get these pictures. Okay. We need to be familiar with the fact that the small bowel is broken into these three sections and roughly where these sections lie, right? So the duodenum is connected to the stomach, right? And it runs from the gastric antrum to roughly the ligament of Treitz, right? So it is largely right upper quadrant, right? The jejunum, it's going to go from the left upper quadrant to the right upper quadrant. And then the ileum is largely the stuff that's on the lower side. Now, I have seen registry questions where they're like pointing at a portion of the small bowel and they're saying, which portion of the small bowel is this, right? In general, those registry questions are asking you to identify the ileum. And the reason for that is it's the only one that's very clearly on the lower part, and students need to be able to differentiate between that spelling ileum and ileum related to like the pelvis, right? So that's ileum with an E. They like to write questions about that. And you can kind of see why. It's easy. I can have an x-ray, point to the lower part, what section of the small bowel is this, and do they recognize that there's a difference between ileum with an I and ileum with an E? It's E for the small bowel. I've not yet come up with a way to memorize that. If someone has a mnemonic for that, that'd be great. The large bowel, what we're talking about in order that stuff travels through it, is the cecum, so that's terminal ileum, or sometimes referred to as the ileocecal valve. That's going to be important for us, so file that away. We're going to come back to it when we talk about hepatobiliary stuff. But that ileocecal valve and appendix hangs down off of the cecum on the right lower side. It goes up the ascending colon, around the hepatic flexure. Hepatic's just the fancy Latin word for the liver, right? So right upper quadrant, across the transverse colon to the splenic flexure, which I've noted is the tallest building, and then down the sigmoid, descending colon to sigmoid rectum and anus, right? The reason I've written tallest building there, and I was going to have a picture of the Empire State Building on this slide, is because that splenic flexure is the highest of all the colon flexures. So when I'm looking at an x-ray and I'm trying to orient myself, and this is particularly helpful if you're doing an oblique view and you're trying to figure out what the heck is that and what's that, just remember that the splenic flexure is the tallest building. It's the highest point. So if it's the tallest thing, I know that's the splenic flexure, i.e. that's the patient's left side. So if I know where the tallest building is, I know what oblique I'm looking at. You can rotate the patient around any which way you want, and as long as I can identify that's the tallest building, I know where the left side is. Does that make sense? Okay. Okay, gastric tubes. These are generally placed through the patient's nose. Probably some of us have an opportunity to assist on these types of things. So another way it might be called is an NG tube. They're more commonly called NG tubes. But the reason is they're called NG tubes is that means nasogastric. We just connected your nose to your stomach is what that means, right? So pretty awkward for everyone involved. We use it for aspiration of gastric contents. If there's something kind of going on, they sometimes call that lavage, where they're pumping junk out. Decompression, removal of contents, or nutritional support. Generally, it's temporary nutritional support. 11 tube is the most common type of NG tube. It's a single lumen. It's generally pretty small. They place it with a guide wire, right? So that's probably what you've seen people having placed. Has anyone by any chance ever had an NG tube placed? Very unpleasant, I would imagine. You feel like you're choking. All right. Enteral tubes deliver nutrition directly to the duodenum and jejunum. So they're placed through the stomach, then they have to get it past the pylorus into the duodenum, right? A common one of those is a Dubhoff tube, okay? And then finally, a nasoenteric decompression tube. These have a balloon at the end, and it's used to stimulate peristalsis, used to remove fluid and gas. Example of that is a Miller-Abbott. They're radiolucent. You can see them on x-ray. You can think about that nasoenteric idea being like a toilet plunger, because that's what it is, right? Just like with a toilet plunger, they're going to inflate this balloon at the end of it, and they're going to pump up and down on it to get stuff out, right? Kind of graphic, but that's what it does.
Makes my sandwich really nice.
Yeah. So already we've found a purpose for these feeding tubes as soon as we get to esophageal atresia. I'm really not sure how this isn't incompatible with life, but apparently kids live with this, and sometimes it winds up opening back up. But it is an absence or closure of a normal body orifice. So that's what atresia means, is absence or closure of a normal orifice. So in esophageal atresia, we have absence or closure of the esophagus. How the heck are they eating? I don't know. I guess they use feeding, like they give them some other form of nutrition. But the symptoms are going to be excessive salivation, which makes sense. If the esophagus is closed, the saliva's got no place to go. It normally drains back, it can't. Sorry for those of us who are eating. Choking and cyanosis, right? Are we familiar with what the term cyanosis means? Yeah, blue lips and stuff like that, right? Diagnosis just means inability to pass the NG tube into the stomach. And so this image I've got here on the right, it's got a black line pointing to the NG tube has folded back on itself and it's going back up the esophagus. So they're trying to put it down into the stomach and it just folded back on itself, right? They have to be really careful with it. If you've ever seen them, they advance the guide wire and then they advance the tube. They advance the guide wire and then they advance the tube kind of stepwise. They have to be really careful with that because you wouldn't want to just keep advancing the guide wire if you're hitting something. Eventually they just advance the tube without the guide wire and it loops back like this. And then they take an x-ray and we've proved that this kid has esophageal atresia. This is commonly done in like pediatric hospitals because it's a much easier way to, and lower radiation to diagnose it this way than with CT, right? So if you wind up doing peds, this might be coming your way. That is the way that it's proved, or they might have the patient swallow a little bit of barium or something that's not barium based in terms of contrast. One thing that can happen related to this is a tracheoesophageal fistula, and that's bad news, right? Because are we familiar with the term fistula, right? By the way, in reading these chapters, I probably used my dictionary more than any other section of the book, right? So hopefully we got our dictionaries out and looked at some of this stuff. But what this is saying, it's a fistula that connects the esophagus to the trachea. That's a problem, right? For a number of reasons. Now we have someone aspirating stuff into their lungs directly from the esophagus, right? So that's commonly coincident at roughly the level of T4, okay? Prognosis is good if it's handled properly. Generally, the treatment is surgery. Okay. We're still in that congenital and hereditary domain of anomalies right now, but we're going to talk about hypertrophic pyloric stenosis, which is just a fancy word for narrowing of the pyloric canal. Okay, narrowing of the pyloric canal. So I have an x-ray image here, and then also one with barium, where you can see the barium sitting there in the stomach, can't cross the pylorus. It is the most common indication for infant surgery. So chances are you know someone or know someone who has had a child who's had to have this. Again, the related signs and symptoms are vomiting, dehydration, no weight gain, right? We're going to talk quite a bit about radiographic appearances. I'll indicate, first of all, sonography is the most common imaging modality to diagnose this because they can very clearly see it without any radiation involved. So in general, it's kind of a coincident finding if we find it on x-ray. But this classic string sign, we're going to see that again. So what's important with the string sign is where's the string, right? In this case, the string is in the stomach. And so in that image on the right, I included it because we see the barium. It can't get through the pylorus, and so there's this little string of barium that was able to worm its way through because it's stenotic. It's closed on. So we have just this little string of barium that's getting through. That's a string sign in this case for hypertrophic pyloric stenosis. Why? Because it's in the area of the stomach. So it's going to be important that it's a string sign, but also where's the string, right? If we get down to the lower bowel, we'll see a string sign down there as well. It means something totally different because the stomach's not there, right? Stomach's in this upper area. So that just know that about the string sign. It is a barium, generally a barium sign, that where we're just seeing a little tiny string of barium get across. We generally incise this area. We cut away at the muscle fibers in order to open up the area of the canal. And the prognosis is normal feeding within days after surgery. So it's a good news. It's common, but it's also fairly easy to treat. And again, like I've said in the past, if I indicate that something is common, it means that you're going to see it quite a bit in X-ray. It also means that's good fodder for registry exam questions and good fodder for my exam questions, right? Because it's common. You can expect to see it a lot, and that's the stuff that we need to know. We need to know the bread and butter stuff. Malrotation, not as common. But what we're talking about is the bowel is not in the normal position. Anytime we see the word malrotation, or honestly the word mal, which is Latin for bad, right? It means bad rotation, not in the normal position. And we can have all sorts of varying degrees of this. In general, it is asymptomatic, but it can lead to a volvulus or incarceration in like an internal hernia, right? And a hernia inside the bowel, which would be incredibly painful. Generally, this is visible with barium enema, and it's going to be important that it's a barium enema, right? Because if this patient is having this kind of problem going on, we do not want to be sending barium down this side. You send barium down this side, it hits that. It's like sending it the wrong way up the traffic jam, right? You just hit the traffic jam. You're not going anywhere. Versus if you go the other direction, go through the barium enema, okay, we can't get past this traffic jam. Okay, it can just turn around and come right back home, right? So very important that we're doing BEs on stuff like this, right? And in fact, the BE might be used to slightly twist things around. They might see if they can press on the patient and move the stuff around a little bit. It has this radiographic appearance in that the stuff's just not where it should be. Like you can see in this case on the left, that is like the transverse colon that looks like it's the descending colon, right? It's all sorts of mixed up. Like the normal loops of the bowel are not where they're supposed to be, right? The one on the right, we can see again, it looks like the transverse colon has pretty much crossed the midline. I mean, the descending colon has crossed the midline. It looks like the ascending colon right now. It's on the other side of the spine. So, malrotation. Okay, Hirschsprungs disease, sometimes called congenital aganglionic megacolon. Aganglionic megacolon. Anytime you see the word A like that, it means absence of something. And in this case, we have an absence of neurons. So you remember from your A&P class, ganglion's a neuron, right? A neuron somewhere in the body. This is saying that the stomach or the digestive system's not doing what it should be doing because it doesn't have neurons attached to it. So that's literally what the term congenital aganglionic megacolon means. It makes the colon look really big. If it goes toxic, so if the ganglia aren't doing what they're doing and causing the movement of stuff through the colon, that area can start to grow bacteria, right? And now you've got toxic megacolon, bacterial overgrowth leading to fluid and electrolyte imbalances. Now, I know that doesn't sound all that serious, but believe me, fluid and electrolyte imbalances are life-threatening, right? So if it goes toxic, you have a life-threatening fatality on your hand. This is occurrence in 1 in 5,000 births, so that's a fairly common occurrence, right? And in general, we are looking for a narrow distal rectum and dilated proximal colon seen on a barium enema. Again, we're going to be doing a barium enema because we want the stuff going into where it can still come out. The child might require a temporary colostomy and multiple surgical resections, right? Okay, celiac sprue, sometimes called celiac disease. Chances are you've known someone who has celiac disease. This is an increased sensitivity to gluten. So now a lot of the cereal companies are releasing how much gluten, or this is a gluten-free product, things like that, because of the incidence of this. The symptoms in general: diarrhea, flatulence, distension when they eat gluten-type stuff, right? Which is gluten's in everything. So the radiographic appearance is good. It's got the segmentation of the barium column. So that means that we've got barium in some places and then not in others, right? So the one on the image on the right shows the segmentation, where it's like stop, start, stop, start, stop, start, different barium patterns throughout, where it should just kind of be barium throughout the intestine. And then flocculation, which just is a fancy word in that it looks like cotton. You can think like a flock of sheep, right? So it has that cottony appearance, and that's apparent more on the image on the left, that cottony appearance. So if you see an image like that, and it's an image of celiac sprue or celiac disease. In general, the diagnosis is done with lab work, and the treatment is it's controlled by diet. Esophageal strictures. These occur in varying degrees. People can have them in different amounts, or greater or lesser amounts. There can be caused by ingestion of caustic materials. So sometimes with suicide people, if they try to drink bleach or something like that, or they accidentally ingest something that was toxic, it can cause this kind of damage to the esophagus, right? It is generally diagnosed with endoscopy. The radiographic appearance, again, is going to be a string-type sign, right? You can see how the barium looks like it's got a string of barium, as well as this kind of almost like, I don't know how to describe it, but almost like web works of barium. The barium's working through a scarred area, right? It's working past scars, okay? A lot of times they, again, use a similar thing to that Miller-Abbott tube. They're going to use a Hirschsprungs dilator, which is something they'll introduce through the nose. And when they get to the area of the stricture, they'll expand the dilator and then leave it there. And it's like almost daily the person's going to have to do this stretch, right? Almost like that's their physical therapy. They're going to do this stretch with a dilator in their esophagus in order to gradually work away or to loosen the scarification of the esophagus. GERD. This is a little bit, this is a funny one. So a lot of people have had reflux to some degree or to lesser degrees or other. But anytime we have repeated reflux of gastric contents into the esophagus, it starts to hurt the esophagus because the stomach has acidic content, right? And so the stomach has things to protect it from the acidic content. The esophagus does not, right? So if there's enough stuff refluxing, and the patient may not even feel it that much, but if they're refluxing a little bit every day, eventually that's going to cause, again, caustic scarification of the esophagus. So in this case, they didn't swallow bleach. They literally had acid coming up out of their stomach and hurting the esophagus. In general, so symptoms related to it is heartburn. That is what heartburn is. Whenever you've had it, that's what that pain is. And esophagitis. It could eventually lead to an infection within the esophagus itself. You have enough damage there, it could cause infection. We're going to use esophageal mammometry, esophagoscopy, I'm sure I mispronounced that, or a barium swallow, to diagnose this. In general, the treatments are also lifestyle type treatments, elevating the bed, so they will sleep upright now, maybe sleep in a chair. Again, why? They're going to be easier to reflux if they're laying down, right? Just because of the way that the gravity works. Avoiding coffee, chocolate, alcohol, so anything fun, and no smoking, right? Decrease, because all those things, the coffee, the chocolate, and the alcohol increase acidity of stomach contents. The smoking, because it decreases the sphincter competence between the esophagus and the stomach. Okay. Peptic ulcers. Again, peptic is just the fancy word for the stomach, right? And pepsin is one of those things that's produced inside of the stomach, and that's where Pepsi gets its name from, right? Pepsi was named because it was originally used to treat stomach illnesses and ailments in some kind of quackery way. Eventually it was repackaged as a soda pop, right? But peptic ulcer, just a little history lesson there. It's most commonly located in the duodenal bulb or the lesser curvature, and the causes are abuse of aspirin, right? Or H. pylori bacteria, which is a common culprit in a lot of problems. So stay away from that stuff. It's bad. Symptoms are going to be pain. In this image here, you just see that that stricture there, or that outpouching, that ulceration, that outpouching on the lesser curvature of the stomach. It looks like the stomach's growing a nose, right? It almost looks like the stomach turned into a fetus, right? It's got that little nose on the lesser curvature, right? Doesn't look terribly painful in the picture, but it is. In general, it's going to be diagnosed with endoscopy or double contrast GI studies. And treatment is a multi-drug therapy or proton pump inhibitor. Neither of those sound particularly fun. Regional enteritis, Crohn's disease. Chances are you've had a patient who has had this complaint. It has an unknown etiology, which means we don't know what causes it. There might be a possible hereditary link. It's not yet been established. It is a chronic inflammation. It typically affects younger adults, both males and females, about equally. It has to be differentiated from ulcerative colitis, right? And the way that we're going to do that is that we will see a transmural inflammation that penetrates all layers of the bowel wall in Crohn's disease. What the heck is that saying? It affects the entire bowel structure. So ulcerative colitis is just going to affect one part of the lumen. This is affecting the entire thing. And that has a number of different appearances. So that's why we're looking for these different radiographic appearances. The cobblestone appearance is going to be caused by mucosal edema, right? So within the mucosa of the intestine, there's edema going on and swelling, right? So we can kind of see that cobblestone appearance, I believe, as indicated by the white arrow here. Tiny, like little cobblestones in that area. A string in the terminal ileus, so that's a terminal ileal stenosis, so there's that string sign, right? It's in the area of the ileocecal valve, right? That terminal ileus, that's what that's saying, which I know is in the right lower quadrant. So it's, again, it's a string sign. The barium's just barely slipping through. So it's important that it's a string sign, but it's also important where is the string, right? The string is in the area of the terminal ileus, the end of the small bowel. And then skip areas, which this entire thing pretty much here is a skip sign, right? So it looks like the barium just skipped something here. I got all this barium and then nothing else around it. The treatment for this is going to be bowel resection if drug therapy doesn't work, right? So drug therapy first and then bowel resection. Now, we've looked at appendicitis quite in depth when we talked about it in CT. So I'm not going to talk too much about the CT appearance of appendicitis. What I want to talk about is its appearance on X-ray, right? It is commonly caused by what we call a fecalith or an appendicolith, which means a stone made out of poop, right? That's literally what that means. It means poop stone, fecalith. Not good for wedding rings, right? But we can actually see in this image here on the right that fecalith has impacted the appendix, and it's actually produced air contrast inside of the appendix. So this fecalith was large enough to impact the appendix and cause air contrast, air to insulfate or fill up the appendix and allow us to see the appendix more clearly on this image. It is the most common abdominal surgical emergency in the United States of America. So it's one of the reasons I'm talking about it. It is apparent on X-ray. It's much more difficult to see on X-ray. But you can imagine before the days of CT, if this is one of the most common forms of abdominal surgery, can you imagine before the days of CT, people died of appendicitis, right? It was a life-threatening condition because if it wasn't discovered, it wasn't treated, you know? So signs and symptoms we all know are right lower quadrant pain. There may be discomfort, nausea, vomiting, increase in white blood cell count like with any other infection. Diagnosis is generally CT or sonography. I think sonography is going to continue to become a go-to standard for this, especially as their imaging procedures improve. And generally, it's surgically removed through a laparoscopic procedure. So chances are you've had chance to see laparoscopic procedures, right? They just make 3 little incisions, go in with robot arms, clip the appendix, make sure the appendicolith didn't fall out inside the abdomen, and then they're done. A common cause, though, just incidentally, a common cause of abscess after appendectomy is that the appendicolith, the fecalith, fell out during surgery, right? So if they're not careful, if they don't catch that stone there as they're removing it, chances are there could be an infection somewhere else in an abscess. So now we're talking about ulcerative colitis, which I said earlier we need to be able to differentiate from Crohn's disease, right? Ulcerative colitis is also an inflammatory lesion of the colon mucosa, but it only affects the mucosa. So if it affects the entire everything of the colon, we're talking about Crohn's disease. If it only affects the mucosa, we're talking about ulcerative colitis. Okay, ulcerative colitis. Again, also has an unknown etiology. That's why it's so important to be able to differentiate these two. We don't know what causes either one of them, and they're both causing inflammations, right? The occurrence is also generally young people, right? So they have occurrence rates during the same age ranges, but the signs and symptoms here are slightly different. Often it's bloody diarrhea and cramping. Diagnosis might be sigmoidoscope or colonoscopy. Again, we want to be mindful of which end we're accessing things at this point. So you notice I'm no longer talking about putting anything down the esophagus. Now I'm talking about colonoscopy, going up through the colon. Okay. Radiographic appearance on barium enema. It's going to be a normal, smooth colon. It's going to now appear irregular, right? So where the colon was normally smooth, now it's going to appear irregular. You can see that in this area right here. That whatever that is really ticked off. Okay. So this is what we would want to see on a dual contrast study. We see this slight inflation of the bowel, and here that's something that's we don't like, right? So the lead pipe sign is a complete loss of haustra. In this case, we see that right here. It looks like a lead pipe, right? So that's a problem and that's a problem. They are related problems. Even though this part is the part that's ticked off, it's causing this over here by the amount of gas and stuff that it's producing, okay? We generally will use dietary restrictions and some form of steroid, but eventually they might require surgery. It depends on whether or not it develops into an obstruction. So one thing to remember to differentiate the colitis from the Crohn's disease is that lead pipe sign. Okay, that it's another yet another way to differentiate between those two is that lead pipe sign. Okay, esophageal varices. This is one thing that we want to bookmark. Okay. Because we're going to come back to this when we talk about cirrhosis, right? Esophageal varices they're varicose veins inside the esophagus, right? So you've probably known someone who's got varicose veins or something like that on their legs. So it's caused by resistance to normal blood flow. In this case, where the resistance is in the liver. So one way to think about this is an uphill result, right? An uphill result. We've got cirrhosis in the liver. There is not normal liver function. We are getting backflow or forced blood up into the varicose veins surrounding the esophagus, and that's causing problems for the esophagus now. So that's what esophageal varices are. They're signs of a more serious condition, right? So they're an uphill result. We're going to see these worm-like defects in the esophagus on barium swallow, right? And this is potentially fatal. If they rupture, that's bad news. So that accounts for about 1/3 of all deaths from cirrhosis. It's not anything related to the liver. The liver's uphill backflow into the esophagus and ultimate rupture of one of those veins. You can imagine that's a deep, deep, deep structure. So even though generally we're not that worried about veins rupturing, if it's that deep inside of someone, that's a problem, right? The treatment is often a sclerotherapy, which means intentional scarification. They're actually going to create stenoses on those veins. They're going to try to push the blood back down to the liver. Banding, again, to try to restrict blood flow to those veins, or vasopressin therapy, which just means giving them a drug that causes the veins to become smaller, right? Another common treatment is a TIPS procedure, and I'm going to try to pronounce this whole thing, a transjugular intrahepatic portosystemic shunt, right? So let's unpack that real quick because there's a whole lot of Latin here. So transjugular, it's going across the jugular vein, right? Within the liver, right? So it's moving stuff basically from the jugular vein through the liver and back and forth. So it's a way of redirecting blood flow from the liver, okay? Redirect blood flow from the liver. So again, we'll come back to this when we talk about cirrhosis. Degenerative diseases. Herniation is going to be the main one. And I want to make sure that we are familiar with these different types of herniations. Herniation just means protrusion of the bowel. It may also be called a bowel rupture. I know that's confusing. The bowel did not actually rupture. It ruptured through the lining around it, right? And now it's got a protrusion into some place where it shouldn't be. Inguinal is for the guys only, right? It literally means a herniation into the area of the scrotum, if I remember correctly, right? That sounds very painful to me. And this picture here with the red arrow is indicating just that, right? So there's a giant air bubble in this person's scrotum, right? The femoral and umbilical can be guys and girls, both. The femoral one is the CT image. I had a hard time finding an x-ray image of a femoral one, but you can see it's there between the femur and the bones of the pelvis. There's a little pouching of bowel, probably small bowel, into that area. That sounds very painful to me too, right? Finally, inguinal is in the area of the umbilicus. And so that the last image here, I don't know if this is barium or what, but we have this giant circle here, which is an inguinal hernia. Umbilical, I'm sorry, umbilical hernia. Sorry about that. Thank you for, okay. Now, we're going to use some fancy words to talk about stuff that's happening when the hernias happen, right? So we are familiar with these hernias are named by where they're at so far, right? Now we can start to name them based on what's happening, what the physiology of this rupture is, right? The first is incarcerated. Think about it being in jail. It's stuck. It can't be reduced. So sometimes some people, it's like, well, if I just push on it and breathe in right, it'll go back in, right? You probably had a patient who's, at least I've had patients who've told me that, right? Talk more to your hernia patients and ask them, like, what can you do with your little friend to make it go back? Strangulation is a problem. So incarceration, that's a problem. If it's stuck, eventually that can lead to strangulation, which means that now it's cutting off blood flow. That's a big problem. You may not be able to feel it, like it might just be the same kind of pain that you normally have, but now it's actually restricting blood flow to somewhere else inside of the digestive system. Now you have necrosis inside of the digestive system. That's a problem. Generally, it's asymptomatic though, right? Okay, I want to pause here for just a sec and talk about my good friend Screaming Jay. One of the reasons I wanted to share that song with y'all, even as goofy as it is or whatever, and that little historical tidbit, is because if this is an important point. This is a highly testable bit of trivia here. This is a common area that the registry asks a question, okay? So I've said about as much as I can to stress the significance of bowel obstructions. They commonly show up on x-ray. If it's a mechanical bowel obstruction, this is caused by blockage of the lumen. The bowel can't, mechanically, it can't get past. Stuff can't get past this point, right? Generally, these are, about half of the cases are caused by strangulating obstructions, like an incarcerated hernia, right? The incarcerated hernia is stopping the flow of stuff through the digestive system, right? Another cause of it can be a gallstone ileus. So put a bookmark by that, because we're going to come back to that when we talk about the hepatobiliary system, right? We'll talk about what gallstones are. But if a gallstone erodes from the gallbladder, forms a little fistula, a connection from the gallbladder now to the small bowel, right? The gallstone just flew the coop on the gallbladder. It's now floating through the floating through the small bowel. It hits that ileocecal valve and wedges there, right? Now we've got backup or obstruction of the small bowel by a gallstone. So we call that a gallstone ileus. And it's actually apparent here on this image right here. You can see that giant gallstone. Sorry, you can't see my arrow. This giant gallstone right here, right? That's a gallstone. Ain't no gallbladder right there. That's the terminal ileus, right? We could also have a volvulus, which is a twisting, usually at the sigmoid or ileocecal junction. So the bowel gets twisted up, either at the area of the sigmoid colon on the patient's left or at the area of the ileocecal valve on the patient's right. And it's like it's tied up in knots, or an intussusception. In this case, it's a telescoping. The bowel has telescoped within itself, and this is also a really popular test question, because this is one of those things where a barium in it is both diagnostic and potentially therapeutic. Has anyone seen those procedures? Like you're doing a dual contrast barium enema, diagnose intussusception, and also potentially treat it. Because just like with a telescope, if it's telescoped and we push enough barium through it, maybe that will make it an untelescope, right? Now we don't have the intussusception there. So the important thing to note on all these pictures is there's a lot of air going on here, right? So I've said it's an obstruction. In my mind, if the bowel is obstruct, it should be full of crap, right? It's not. It's full of air. The crap is what caused the obstruction, and now it's just filling up with air. So if you notice here on this KUB, tons of air on this. This is actually a CT topogram. And look, we didn't even need to do the rest of the scan. We've already diagnosed obstruction. And this is crazy how much obstruction there is there. Now, if it is an intussusception, two common signs with intussusception is this crescent sign, where there's like it's crescent shaped. No part of the bowel should be crescent shaped, right? We should see tubes running every which way. We shouldn't see crescents. If you see crescents, something's wrong with the tubes, right? Or you might just see this coiling up of stuff, right? Coiling up of stuff. The important thing here is all of the air. Because what they like to ask a test question about this, because it's so counterintuitive, that if the bowel is obstructed, it's full of air, I need to decrease my radiographic technique. That's why they like to ask questions about it. Because it's counterintuitive and it's also common. We see a lot of it and it requires a reduced technique. It's counterintuitive though. There is one other form of obstruction, and we call it a paralytic ileus. And the fancy word for this is adynamic ileus. And I said if there's that A out in front, it means something's not doing something. And in this case, the ileus isn't moving stuff around. It's a failure of peristalsis. And a lot of times these people will have vomiting, distension, real pain, like Screaming Jay Hawkins said. And we will see a lot of gas. Right, again, same result, reduced radiographic technique. Still an obstruction. That is a ton of gas in that person. Gas is visible throughout the colon. We might be able to treat this with NG suction or medical stimulation of the bowel, right? So again, this is another one of those cases where your work fluoroscopically, the doctor may be trying to cause some stimulation of the bowel. They may be pressing on the patient in order, hopefully, to stimulate some peristalsis. Okay, diverticular disease. Now, there's three different spellings on this slide, if you notice, and I want to point that out to you. Diverticular, right, is a normal kind of thing. Like it just means a pouch or a sac. So there are colonic diverticula that are part of like the hostra. It's just another way of thinking about that. If it's diverticula, that is plural. In the Latin world, the A ending on that declension of nouns is plural. So colonic diverticula means pouches or sacs, right? It happens in a lot of people. And especially as you get older, roughly 50% of patients over 50 years old have a hypertrophy of the muscular layer of the bowel, which causes these sacs, right? If it becomes inflamed, if something gets stuck in it and it gets ticked off, we call that diverticulitis, and that is exacerbated by feces trapped in the diverticulum, right? That is a singular, that's Latin singular, diverticulum, right? Signs and symptoms of this are left lower quadrant pain, not right lower quadrant pain. So sometimes it's called left side appendicitis because it's basically the same kind of pain. It's just on the other side of the body, and it can lead to obstruction. This x-ray is crazy. I mean, the number of diverticula on this image. Has anyone ever seen this stuff on x-ray? I mean, that's a pretty good case to study right there. Generally, you might see 2 or 3 of them or something. I mean, that's I didn't even count. It's close to 20. We will see BE extraluminal. That just means not in the area of the normal bowel, right? Or intraluminal contrast. So there might be increased amounts of contrast within the lumen itself, so within the bowel itself. We normally try to ask these people to stop eating corn, right? Can't eat any more corn because the corn is pretty much indigestible, gets stuck inside these diverticulum, and then you've got inflammation, right? So a lot of times the treatment is things like diet, but if it has resulted in inflammation or infection, it might be antibiotics. If it doesn't improve, it could be possibly surgery. Okay, we're winding down towards the end here. Just got 3 or 4 more slides. But let's talk about neoplastic disease. The first that I'm going to mention is the most rare of them, but I'm going to mention it for some reasons. Normally, tumors of the stomach are malignant. So about 95% of them are adenocarcinomas. They are carcinomas, right? They have a high incidence of metastases. They are largely asymptomatic until the cancer has become late stage, right? So that's why I'm mentioning it. Its occurrence differs by geography, ethnicity, diet, heredity, and sex. It has a crazy, weird way that it occurs, right? And the symptoms, once it is late in the game, are GI pain, bleeding, vomiting, loss of appetite, weight loss, and early satiety. Where it normally shows up for most people is just weight loss and early satiety. Satiety just is the fancy word for I'm full. I've had enough to eat, right? If your stomach's developing a little tumor friend inside of it, you get full quicker, right? Because there's not enough room for tumor and your food, right? So that's what early satiety means. And where the person's basically, in most cases, if people have loss of appetite in America, we tend to think, oh, that's a good thing. You know what I mean? Like, now I can eat whatever I want, and I'm losing weight. So it's not until the other stuff starts to show up, and by that time it's too late for reasonable treatment because of its high incidence of metastases. Generally, it's diagnosed incidentally on CT, right? Incidentally means, oh my gosh, this person's got a cancer on their stomach, right? The radiographic appearance is just filling defects. So in this case, we have what sometimes is called an apple core sign, right? Or what's happened in this case, you can see the barium is kind of hit the pyloric area, and it's just kind of funneled down. It's not quite a string sign, but it looks like an apple core right here, right? What's around that apple core is the tumor. The tumor is wrapped around the entire stomach. We're not able to see the tumor on this image, but we can see the effects of it. Treatment is generally surgery. It's not one that's very responsive to chemo or to radiation therapy. So the reason I'm mentioning it to you is because of its rarity, but also because of its high incidence of malignancy. Colonic polyps. These are little tumor friends that we pretty much all developed over the course of our lives, right? We can use a bunch of different weird scopes to look at these things, or we can use a barium, like an air contrast barium enema. We're going to see these rounded filling defects on air contrast BE. So in this case, we've got a little tiny polyp here. They've applied the paddle to it to kind of separate out pieces of the bowel, and you can see that little rounded looks like a little mushroom inside the bowel, right? So they are adomnatous. Adomnatous, which means that they have a benign origin. They start out just little mushrooms, right? But they can become malignant. The fancy word for that is a dysplastic change. Dysplastic change. That means bad change. Dysplastic literally means bad change, right? So it went from being benign, had a bad change, now it's malignant, right? So it's a little benign mushroom, bad change, dysplastic change, now it's an evil mushroom. If it's sessile, that means it's attached directly to the bowel wall. Sessile means it's attached directly to the bowel wall. Pedunculated meaning it's on a little tiny stalk. I don't know how to remember that. You just have to remember that. Pedunculated, tiny stalk. It's an amazing word, though. You got to admit, pedunculate's a good word. It's a good word. Colon cancer. All right, this one's probably the biggest takeaway. Look, there's another apple core sign, right? So we just had another apple core sign, but where is it? It's not in the stomach. It's in the colon. So the same thing is now going on. Same sign, different place. It's still a tumor. Tumor is strangulating this thing and wrapped around the colon now, right? Colon carcinoma is a common malignancy in the United States of America. Someone that you know is going to be impacted by it at some point in their life. It's the second most common cause of cancer death, which is scary. 1 in 20 chance of developing it at some point in time in your life, which is crazy when you think about it. So the factors include family history, a diet high in sugar and animal fat. That describes every American I know, right? Every commercial that's on the Super Bowl, pretty much, right? So adenocarcinoma is derived from glandular epithelium. In general, it's related to polyps. So guys, go get your colon scoped, right? Because if we can catch this thing before it goes through that dysplastic change, we can catch it before it becomes cancerous, right? The radiographic appearance of it, again, is that apple core sign, or sometimes called a napkin ring sign, where the cancer has wrapped around the bowel and it's starting to cause just a small amount of barium to get through. Okay, last thing here is just being able to look at these things, and this slide is terrible, but the thing to circle right here is bowel obstruction subtractive. Bowel obstruction subtractive, and you are good to go.